Howdy, folks. Welcome to Reading Cowboy's Deep Dives Heart Health Series. Grab your spurs and settle in, because today we're wrangling up some vital information about keeping your most important muscle, your heart, in tip-top shape. Ever wondered if a little daily aspirin is always a good idea? Or maybe if those leafy greens you're told to eat can actually mess with your medication? Perhaps you've heard about blood thinners and pictured your blood turning into, well, water. Or maybe you're wondering if skipping the gym for a Netflix binge really does put a strain on your ticker. Well, partner, we're here to cut through the tall grass and get right to the simple truths. We promise simple explanations, maybe a few good laughs, and practical tips you can use faster than a tumbleweed in a dust storm.
That's right. We'll be your guides today, navigating the twists and turns of heart health, particularly around those medications we often call blood thinners. What's fascinating here is how much misinformation, or sometimes simply a lack of clear understanding, can surround these crucial treatments. We're going to help you understand not just what these medicines do, but why they matter to your everyday life.
Today we're embarking on a deep dive into the world of medications that help prevent dangerous blood clots. We'll cover what they are, how they work, who should use them, and crucially, how to live safely and smartly if you're on them. Think of it as science meets cowboy charm, where we'll maybe laugh a little while we learn to love our heart. So let's unpack this. First off, let's clear up a common misconception, shall we? When we say blood thinners, it sounds like we're turning your blood into water. But that ain't quite right, is it?
Precisely. It's a widely used term, but these medicines don't actually make your blood thinner in the sense of reducing its viscosity or making it watery. Instead, their fundamental role is to make it harder for undesirable blood clots to form or to increase the time it takes for blood to clot when it needs to. Think of your body's circulatory system like, say, a network of vital pathways, like pipes. You want these pathways to remain clear, right? Unobstructed. Blood thinners, then, are kind of like a specialized maintenance crew. They work to prevent the sticky components of your blood, primarily platelets and various clotting factors, from clumping together and forming a blockage, a dam in your pipe, so to speak. They ensure a steady flow rather than actually changing the fluid consistency of your blood.
That distinction is really helpful. So they both aim to keep things flowing, but they ride different trails to get there, as we might say. You mentioned two main categories, two processes of protection. Can you break down these two main types for us?
Absolutely. Understanding these two is key. First, we have antiplatelets. These medications work by preventing tiny blood cells, called platelets, from sticking together. Platelets are sort of like the first responders to an injury. They rush to the site, clump up, and start forming a plug. Antiplatelets effectively, calm down these platelets, making them less prone to forming unwanted clumps that could lead to a clot inside an artery. This is especially important for preventing clots in conditions affecting the arteries, things like heart attacks and certain types of strokes.
Okay, so that's antiplatelets targeting the sticky little cells. What's the other group?
The second category is anticoagulants. Now, these take a different approach. Instead of directly targeting platelets, they interfere with specific proteins in your blood. These proteins are known as clotting factors, and they're essential for the more robust, mesh-like clot formation that happens later. By inhibiting these factors, anticoagulants essentially increase the time it takes for your blood to clot. Makes it much harder for large, dangerous clots to develop or to grow larger if they've already started. These are often used for conditions where clots might form in veins or perhaps in the heart chambers themselves. Think deep vein thrombosis, DVT, pulmonary embolism, PE, or atrial fibrillation, AFib.
Got it. So antiplatelets stop the initial clumping. Anticoagulants slow down the whole clotting process later on. Different trails, same goal, keeping the pipes clear. But why is preventing these clots so critically important? What are the real dangers if they do form?
And that really is the why behind all of this, isn't it? Blood clots pose a significant threat, a huge threat actually, because they can block the flow of blood to vital organs. If a clot blocks an artery supplying blood to your heart, that can lead to a heart attack, damaging heart muscle permanently sometimes. If it blocks a vessel in your brain, it causes an ischemic stroke. That leads to brain damage, potential long-term disability, devastating consequences. Clots can also form in the deep veins, usually in the legs. That's deep vein thrombosis, or DVT.
Right, I've heard of DVT.
Exactly. And if a piece of that DVT clot breaks off and travels through the bloodstream to the lungs, it can cause a pulmonary embolism, or PE. A PE obstructs blood flow and oxygen exchange in the lungs. It's a life-threatening emergency.
Wow. Okay, so these aren't minor issues we're talking about preventing.
Not at all. These medications are about preventing potentially devastating medical events, which naturally raises an important question. Given these different types of medicines and the serious risks involved, how do doctors decide which one is the right choice for a specific person? It's clearly not a one-size-fits-all situation.
You're absolutely right. That choice is crucial. Let's saddle up with one of the most well-known names in this whole discussion. Aspirin. Most folks have a bottle of it in their medicine cabinet, right next to the bandages probably. We reach for it for a headache, muscle ache. But when it comes to heart health, its role is much more specific. And frankly, the advice has become a bit more nuanced over the years than just take one and call me in the morning.
Indeed, it has. Aspirin, as we'd categorize it based on what we just discussed, is an antiplatelet drug. Basically, it works by making those tiny blood cells, the platelets, less sticky, less likely to clump together and form that initial clot. You can almost think of it like putting a permanent off switch on a specific function of the platelets that kicks off clotting. This effect helps keep blood flowing smoothly through the arteries. Historically, aspirin has been, well, a cornerstone for both primary prevention, that means preventing a first heart attack or stroke in people considered at risk, and secondary prevention, which is preventing a repeat event in folks who've unfortunately already experienced a heart attack, stroke, or some other related cardiovascular event. It's also really crucial in acute situations like acute coronary syndrome, ACS, or after procedures like getting a stent placed, PCI, and for conditions like peripheral vascular disease, PVD. So it's been a very powerful, very versatile tool for a long time.
Sounds incredibly useful. But like you said, the advice around taking it daily has shifted, hasn't it? It feels like just a few years back, almost everyone was being told, oh, take a baby aspirin a day, it's good for you.
Yeah.
What's driving this change? What should someone listening right now understand about whether daily aspirin is right for them?
That's a critical point, and it's a perfect example of how medical understanding evolves as we get more research, more data. The guidance on aspirin specifically for primary prevention, again, that's for people who haven't yet had a heart attack or stroke, has changed quite significantly. It's now understood that daily aspirin therapy should only be initiated under the specific guidance of a healthcare provider. It's really not a universal recommendation anymore. And the main reason is that we've gained a much clearer picture of the balance between its benefits and its risks. It's not a harmless pill. The U.S. Preventive Services Task Force, the USPSTF, they give us some clear recommendations here. For adults aged 40 to 59 years who have a 10% or greater 10-year risk of cardiovascular disease, or CVD, the decision to start low-dose aspirin is now considered an individual one. Meaning you and your doctor need to sit down and have a detailed discussion. You have to weigh the potential benefits, which are considered small in this group, against the very real risks for your specific situation. The net benefit overall is generally thought to be small. Now, if you're someone not already at increased bleeding risk and you're willing to take it consistently every day, you might see a small benefit. This is what they call a C recommendation, which really emphasizes that clinical judgment and patient preference are key.
Okay, so for the 40 to 59 group with higher risk, it's a maybe and a definite talk to your doctor situation. What about older folks?
Right. For adults aged 60 years or older, the USPSTF now recommends against initiating low-dose aspirin for primary prevention of CVD.
Against? Wow.
Yes, against starting it. This is a D recommendation, which is a stronger recommendation indicating that for most people in this group, the potential harms outweigh the potential benefits. The reason for this shift is a better understanding of aspirin's potential harm. The very same properties that make it good at preventing clots also significantly increase the risk of serious side effects. We're talking about things like bleeding into the brain, a hemorrhagic stroke, or significant bleeding in the stomach or intestines, which can lead to ulcers or worse. As we age, the risk of these bleeding complications naturally tends to increase. So for many in this older age group who haven't had a prior cardiovascular event, the potential harm simply outweighs the modest benefit.
That's a really powerful and important distinction. So for anyone listening, it sounds like the key takeaway is the benefits of aspirin for preventing a first heart attack or stroke aren't as clear-cut as we once thought, especially as we get older. And the potential for serious bleeding is a real concern that needs to be factored in. This isn't a decision to make lightly or just start doing on your own based on old advice.
Exactly. And it's crucial here to differentiate this from secondary prevention.
Right, you mentioned that earlier.
If you already have a history of a heart attack or a stroke or known blood vessel disease, then aspirin does work effectively, and your doctor will very likely recommend it as part of your ongoing care. In those cases, the established benefit of preventing another potentially life-threatening event typically far outweighs the bleeding risks, which of course are still monitored and managed by your medical team. But again, that individual conversation with your doctor is absolutely paramount. They need to assess your unique risk factors, consider any other medications you're taking, and help you make the most informed decision.
That brings up another interesting point. Sometimes aspirin isn't riding alone, so to speak. It might be prescribed alongside other common heart medications, like statins drugs, like Lipitor, for example. What's the dynamic there? Are they working together, or could they interfere with each other?
That's a great question, because this combination is actually quite common and often very beneficial. The short answer is yes, combining aspirin with statins is generally safe and frequently recommended.
Okay, good to know.
The good news is that these two types of medications, aspirin and statins like atorvastatin, Lipitor, or rosuvastatin, Crestor, do not have negative interactions of concern when taken together specifically for heart health. In fact, they complement each other really nicely by targeting different aspects of cardiovascular risk. Think about it this way. Statins, like Lipitor, work primarily to lower your bad cholesterol, the LDL-C. This helps prevent the buildup of fatty plaques in your arteries. Statins are reducing the dunk, you could say, that narrows your blood vessels over time. Aspirin, on the other hand, works to prevent blood clots from forming on top of any existing plaque, or from forming if a plaque happens to rupture, which is often the trigger for a heart attack or stroke.
So one deals with the plaque buildup, the other deals with the immediate danger if that plaque causes trouble.
Exactly. One addresses the underlying buildup, the other prevents the acute, dangerous consequences. They effectively work in tandem, like two different ranch hands, keeping the herd healthy, if you want to stick with the theme. If you've had a heart attack, or you have stents in your arteries, or you've undergone bypass surgery, it's very, very common for doctors to recommend taking both low-dose aspirin and a statin daily. This combination offers pretty robust protection. However, even when they're combined, you and your doctor still need to be mindful of that increased risk of gastrointestinal bleeding from the aspirin component. It doesn't negate the risk, but the combined benefit is often worth it under guidance.
So it's not a case of too many cooks in the kitchen. They're actually addressing different problems that could both lead to serious heart issues if left unchecked. That's a powerful combination for those who need it. So the practical daily tip here seems clear. If you're thinking about adding aspirin to your daily routine, or maybe you're already on it and wondering about these newer recommendations, remember the golden rule. Chat with your healthcare provider first. They know your full medical history, your other conditions, your other meds. They can help weigh the specific benefits against the potential risks for your unique situation. Don't just follow the crowd or rely on something you heard years ago. Get that personalized assessment. All right, beyond aspirin, there's that whole other crew of blood thinners we mentioned, the anticoagulants. These are often prescribed for more specific situations, maybe more serious ones, and they use a different playbook than aspirin.
That's an excellent distinction to make. One of the veterans in this anticoagulant crew, one of the most long-standing and well-known, is warfarin. You might know it by brand names like Coumadin or Jontopin. Warfarin has been a critical medication for decades. Its mechanism is quite precise. It's a vitamin K antagonist.
Vitamin K antagonist, what does that mean exactly?
It means it works by directly interfering with the action of vitamin K in your liver. Vitamin K is absolutely essential for the liver to produce several key proteins. These are the clotting factors we talked about earlier that are necessary for your blood to clot effectively when it needs to. By reducing the availability of active vitamin K, warfarin essentially slows down the production line for these clotting factors. This makes your blood take significantly longer to clot. Now, an important point about warfarin, it doesn't work instantly. It actually takes a few days for the body to use up the existing clotting factors that are already circulating before warfarin's full effect kicks in. And because its impact can vary quite a bit from person to person and can be influenced by things like your diet and other medications, you take people on warfarin need regular blood tests.
Right, the INR test.
Exactly. These tests measure something called the INR, or International Normalized Ratio. The INR value tells your doctor precisely how long it's taking for your blood to clot. It's a very delicate balance. You need to keep the INR within a specific therapeutic range, not too high because that means excessive bleeding risk, but not too low because that means you're not protected enough from dangerous clots. It's like tuning a banjo. You need to get the tension just right. Your doctor helps manage this, precisely adjusting the warfarin dose to keep you safe and protected. Warfarin is commonly prescribed for conditions like atrial fibrillation, AFib, that irregular heartbeat that can let clots form in the heart, or after someone gets an artificial heart valve, or for treating existing clots like a pulmonary embolism, PE, or deep vein thrombosis, DVT.
Okay, so warfarin is a powerful tool, a real workhorse, but it definitely requires careful ongoing management to maintain that critical balance.
Yeah.
But I understand there are newer options now, maybe a bit more streamlined. What are these new kids on the block doing differently?
You're right. Since around 2008, we've seen the emergence of a newer class of anticoagulants. They're known as direct oral anticoagulants, or DOACs. Sometimes people still call them NOACs for novel oral anticoagulants. Examples include medications like apixaban, brand name Eliquis, dabigatran, Pradaxa, rivaroxaban, Xarelto, and edoxaban, Lixiana or Savesa. What sets them apart is their more direct and often more predictable action. Instead of broadly interfering with vitamin K like warfarin does, these DOACs directly inhibit specific clotting factors in the blood clotting cascade.
More targeted then.
Exactly. This targeted approach generally means they start working much faster than warfarin, often within just a few hours of taking a dose. And a significant advantage for many patients, a really big one, is that, generally speaking, DOACs do not require routine blood monitoring like those frequent INR tests needed for warfarin.
Oh, that's a big difference.
It is. It simplifies treatment considerably for many people. Fewer clinic visits, no regular blood draws just for monitoring the drug level. However, it's crucial to remember, while they simplify management in some ways, they still carry a significant bleeding risk. And adherence, taking the prescribed dose exactly as directed, on time, every time, is absolutely critical. Missing doses can quickly leave you unprotected. Their indications are very similar to warfarin. They're widely used now for preventing stroke in people with AFib and for treating and preventing DVT and PE. They've certainly offered a valuable alternative for many, reducing that burden of frequent monitoring.
Makes sense. So oral options. Warfarin, the veteran, and the DOACs, the newer direct agents. Are there others?
Yes, beyond these oral options, we also have an important category of injectable anticoagulants. We could maybe call them the support squad or the quick response team for acute situations. These include drugs like heparin, which actually comes in different forms, like low molecular weight heparin, such as enoxaparin, Levinox, and dalteparin, Fragmin, and also fondaparinux, Arixtra. These are typically given by injection, often just under the skin, sometimes intravenously in the hospital. Their primary role is in acute, time-sensitive situations, like the immediate treatment for an existing DVT or PE where you need to stop clot formation fast. They're also vital for preventing clots after major surgeries or during periods of prolonged immobility, like a long hospital stay, where the risk of clots forming is significantly higher. Think of these injectables as providing immediate, powerful protection when time is absolutely of the essence. They often bridge the gap until an oral anticoagulant like warfarin or a DOAC can take full effect.
Okay, so it's clear that even within this anticoagulant group, there's a whole range of strategies and tools. You've got the carefully managed warfarin, the more streamlined DOACs, and then the rapid action injectables for emergencies or specific situations. It really highlights how personalized treatment needs to be. Now, here's where things can get a bit tricky, maybe like trying to herd cats. If you're on a blood thinner, it's not just about remembering to take your pill. What you eat, what herbs or supplements you might take, even other medicines, prescription or over-the-counter, can all throw a wrench in the works. They can interfere. Let's talk about keeping your system running smooth and avoiding those complications.
This section is absolutely vital. Crucial, really, for anyone on these medications, especially anticoagulants. Let's start with the vitamin K story, particularly for warfarin users. As we discussed, vitamin K is a natural nutrient, essential for blood clotting. And warfarin works by directly blocking its action. Because of this very direct relationship, the golden rule, if you're taking warfarin, is to maintain a consistent vitamin K intake from week to week.
Consistency, not elimination.
Exactly. This isn't about avoiding healthy vitamin K-rich foods entirely. It's about avoiding sudden, large fluctuations in how much you consume. Why? Because a sudden increase in your vitamin K intake can make warfarin less effective, potentially raising your risk of forming dangerous clots. Conversely, a sudden decrease in vitamin K can make warfarin too effective, significantly increasing your risk of bleeding.
Makes sense.
Yeah.
Keep the campfire steady, so to speak. So what are these high vitamin K foods we need to be consistent about?
They're often the very healthy green leafy vegetables that doctors usually encourage us to eat. Things like spinach, broccoli, cabbage, collard greens, turnip greens, beet greens, mustard greens, dandelion greens, kale, Brussels sprouts.
A lot of the good stuff.
Exactly. Also, certain oils like canola oil and soy products contain vitamin K. The practical advice isn't don't eat these. It's if you typically eat, say, a moderate amount of broccoli each week, continue to do so consistently. Don't suddenly decide to go on a massive kale smoothie kick every single day if you haven't been, or abruptly stop eating all green vegetables entirely if they were part of your regular diet. Keep your dietary patterns as stable as possible. And speaking of intake, it's also really important to check with your doctor or dietitian before taking any dietary supplements like Ensure or Boost, or any vitamin supplements, especially those containing vitamin K itself, or even large amounts of vitamins A, E, or C, as these can potentially alter warfarin's effectiveness too.
A good point about the supplements. Okay, so consistency with vitamin K for warfarin users. Beyond food, many people use herbal remedies. Is there an herbal hoedown we need to watch out for? Any specific herbs that clash with blood thinners?
Absolutely, and this is a major area of potential danger, often overlooked. Many common herbs and herbal supplements can seriously interfere with blood thinners, significantly increasing your bleeding risk. The critical mindset here should be assume an interaction unless it's been explicitly cleared by your doctor or pharmacist. Don't assume natural means safe when you're on these medications. It's like some of these herbs have their own subtle thinning properties, or they interfere with how your body processes the medication. Doubling up, even unknowingly, can lead to very dangerous bleeding.
So always check first. Are there common examples?
Yes, always check. Some specific herbs known to potentially interact include things like chamomile, echinacea, clove, evening primrose oil, dongquai, licorice, ginseng, ginkgo biloba, golden seal, St. John's wort. Even things like high doses of garlic, ginger, or turmeric supplements might pose a risk. Willowbark, for example, contains natural salicylates chemically similar to aspirin. Combining that with a prescribed blood thinner is just asking for trouble. It's a surprisingly long list, isn't it? It really highlights why you need complete transparency with your medical team about everything you're taking: prescriptions, over-the-counters, vitamins, herbs, everything. A simple supplement you think is harmless could have serious consequences.
That's a powerful warning. It's not just what's in the prescription bottle, but the supplement cabinet too. What about everyday drinks? Any liquid liabilities we should be wary of?
Yes, even some common sips can cause trouble. Alcoholic beverages, cranberry juice, and grapefruit juice are the main ones to be cautious about. Alcohol, particularly in anything more than very moderate amounts, can both directly increase bleeding risk and interfere with how your liver metabolizes certain blood thinners, potentially making them dangerously potent. Cranberry juice and grapefruit juice can also influence the metabolism of certain medications, including some blood thinners, potentially increasing their levels and, consequently, your bleeding risk. The safest bet is generally to avoid these as much as possible when you're on blood thinners. Or if you do consume them, only do so in very small, consistent amounts and only after a thorough discussion with your doctor. Even small changes in your intake of these could impact your medication safety. Consistency and communication are key.
Consistency again. Okay, food, herbs, drinks. What about other actual medications? This sounds like the pharmacy puzzle.
It really can be a puzzle, and this is perhaps the broadest and potentially most dangerous category of interactions. Many prescription and over-the-counter medications, even ones you wouldn't necessarily think of as affecting blood clotting, can dangerously interact with your prescribed blood thinner. What's fascinating, and a bit scary, is the sheer diversity of these interactions. Some interfere with absorption, some affect the liver enzymes that break down the blood thinner, some have additive effects. This means that something as simple as an over-the-counter headache remedy or a common cold medicine you grab off the shelf could have serious, unforeseen consequences if you're taking a blood thinner.
Wow. So what are some of the key culprits we should know about?
Okay, key culprits to be extremely cautious with. First, NSAIDs. Non-steroidal anti-inflammatory drugs. These are super common pain relievers: ibuprofen, Advil, Motrin, naproxen, Aleve, diclofenac, and others. They pose a double whammy risk. They have their own mild blood-thinning properties, and they can irritate the stomach lining. Combining them with your prescribed blood thinner dramatically increases your risk of severe gastrointestinal bleeding. Acetaminophen or Tylenol is generally considered a safer choice for pain relief if you're on blood thinners, but always check with your doctor first. First, NSAIDs, non-steroidal anti-inflammatory drugs. These are super common pain relievers. Also, watch out for bismuth subsalicylate. This is the active ingredient in things like Pepto-Bismol. It's chemically related to aspirin. It's a salicylate, and similarly increases bleeding risk when combined with other blood thinners.
Okay, NSAIDs and Pepto-Bismol, common things, big risks. What else?
Beyond those, the list gets quite long. Many common antibiotics can interact, particularly with warfarin. Examples include metronidazole, fluoroquinolones like ciprofloxacin and sulfamethoxazole trimethoprim, Bactrim. Certain antifungal drugs, like fluconazole, are potent inhibitors of the enzymes that break down warfarin and some DOACs, leading to much higher drug levels. Some blood pressure medications, various antidepressants, especially SSRIs and SNRIs, common seizure medicines like phenytoin, phenobarbital, carbamazepine, important irregular heart rhythm medications like amiodarone, and even newer medications like the COVID-19 antiviral Paxlovid, nirmatrelvir-ritonavir, have significant interactions with certain blood thinners, particularly some DOACs. The ritonavir component is a strong enzyme inhibitor. Many of these interactions happen because these other drugs affect the specific liver enzymes, often called CYP enzymes, that are responsible for metabolizing your blood thinner. They can either speed up the breakdown, making the blood thinner less effective, or slow it down, making it dangerously potent.
That is an astonishingly long and varied list.
Yeah.
It really hammers home the point that just reading labels might not be enough, because the interactions aren't always obvious. This all seems to boil down to one simple, absolutely crucial piece of advice, doesn't it?
It really does.
Whenever you're about to take anything new, whether it's a vitamin, a supplement, an over-the-counter cold remedy you picked up for a sniffle, or a new prescription from a different doctor or dentist, always, and I mean always, check with your primary doctor or your pharmacist first, before you take the first dose. They have the full picture, they have the databases, they are your best resource for navigating these potential minefields. They're your co-pilots on this trail. A quick phone call can literally save you from a serious complication. All right, so we've talked about how these essential medicines work, why they're needed, and what can interfere with them. Now let's get really practical about the biggest potential downside, the main risk we manage: bleeding. It sounds scary, sure, but with a few smart habits, a bit of awareness, you can significantly lower this risk and keep yourself safe on the trail.
You're absolutely right. Understanding the risk is the first step to managing it effectively. The primary side effect of all blood thinners, whether antiplatelets like aspirin or anticoagulants like warfarin or the DOACs, is an increased tendency for bleeding. This bleeding can range from minor, more nuisance-level things, maybe more frequent nosebleeds, seeing a bit of pink on your toothbrush from your gums, bruising more easily from small bumps, all the way up to very severe, potentially life-threatening internal bleeding. Bleeding into critical areas like the brain or significant bleeding within the stomach or intestines. It's important to keep reminding ourselves the medication isn't truly thinning the blood in the sense of making it watery, it's making it slower to clot. So any injury, whether it's an external cut or scrape, or even just an internal bump or bruise, means your body's natural clotting response will be delayed or less effective. This leads to bleeding for longer or bruising more extensively than you normally would. This increased bleeding risk is the necessary trade-off, the price we pay, if you will, to prevent those dangerous, potentially fatal clots from forming. It's a calculated risk. And several factors can further increase an individual's bleeding risk. Things like being on a higher dose of the medication, being older, taking other medications that also affect clotting, especially NSAIDs or another blood thinner, having chronic kidney or liver disease, certain underlying blood clotting disorders, having active cancer, or consuming heavy amounts of alcohol. Your doctor considers all of these when deciding on the right drug and dose for you and when monitoring you.
That puts the risk into clear perspective. It's a calculated trade-off for a significant benefit. So if we're accepting that risk, it means following our doctor's orders becomes absolutely golden. Their guidance is our map and compass here.
Absolutely. Following medical guidance meticulously is paramount. Number one, perhaps most critically, take your medication exactly as directed. Never skip a dose. Never take more than prescribed. Never adjust your dose on your own without explicit instructions from your doctor or pharmacist. If you accidentally miss a dose or realize you take an extra one, don't guess what to do. Call your pharmacist or doctor immediately for directions. Never try to make it up on your own. For drugs like warfarin, those regular blood tests, the INR tests, are absolutely essential. They are not optional. They ensure your dose is precisely right, keeping you in that safe and effective therapeutic window, managing that tightrope walk between clotting and bleeding.
Okay, take as directed, call if you mess up, do the blood test as needed. What else?
Communication. It's vital to communicate openly and thoroughly with all of your healthcare providers. That means your primary doctor, any specialists you see, your pharmacist, your dentist, everyone involved in your care. Always make sure they know you're taking a blood thinner. It's a really good practice to carry an up-to-date list of all your medications, drug name, dose, how often you take it with you at all times, maybe in your wallet. This helps prevent dangerous mix-ups, especially in emergencies, and ensures everyone on your team has the full picture.
That's a great practical tip. carrying the list.
It really is, and a particularly critical point, especially for heart patients. If you have a heart stent, you must not stop taking your anti-clotting medicines, often aspirin plus another antiplatelet like clopidogrel, without first talking to the cardiologist who placed your stent.
Why is that so critical?
Because stopping those medications prematurely, even for a few days, can lead to a very dangerous and potentially fatal clot forming inside the stent itself. It's called stent thrombosis. It's a medical emergency, so never stop those on your own if you have a stent. Finally, regarding procedures, if you're scheduled for any kind of surgery or even some dental procedures or other invasive tests, you might be told to temporarily stop your blood thinner beforehand. This needs to be very carefully coordinated and managed. It requires clear communication between the doctor who prescribes your blood thinner and the doctor or dentist performing the procedure. They need to agree on when to stop it, if needed, and crucially, when to safely restart it afterwards. This is never a decision you should make on your own.
That's incredibly comprehensive advice on the medication side. It really underscores how crucial communication and adherence are. Now, beyond managing the medicine itself, what practical steps can we take in our daily lives? How can we sort of holster our habits to minimize those bumps, scrapes, and falls that could lead to bleeding?
Excellent question, because proactive prevention makes a huge difference here. It's about being more mindful, more aware of potential hazards, and making slightly different choices in your daily activities. Home safety. First, take a look around your home. Make it as safe as possible to prevent falls. Clear clutter from walkways and stairs. Secure any loose rugs with non-slip backing or tape them down. Ensure you have good lighting, especially at night. Consider installing grab bars in the bathroom near the toilet and shower if balance is sometimes an issue. Physical activity choices. You don't need to stop being active, but you do need to be smart about your choices. Avoid contact sports. Think football, hockey, rugby, even aggressive basketball where collisions are likely. Also, steer clear of activities with a high risk of serious falls or trauma like downhill skiing, rock climbing, or maybe horseback riding, unless you're very experienced and take extra precautions.
So that's generally okay.
Non-contact sports and activities are usually fine and encouraged. Things like walking, swimming, cycling, wear a helmet, dancing, golf. These are generally much safer. But even then, using appropriate protective gear when relevant, like helmets for cycling, is always a good idea. Shaving. This is a simple one, but important. Use an electric razor instead of a traditional blade razor. Even a tiny nick from a blade, which might be nothing normally, could bleed for quite a while if you're on a blood thinner. Hand protection. Protect your hands. Always wear gloves when you're using sharp tools like kitchen knives, scissors, box cutters, or when you're gardening, doing yard work, or handling anything rough or sharp that could cause a cut or scrape. Foot protection. Your feet are vulnerable too. Do not walk barefoot, especially outdoors, but even indoors if there's a risk of stepping on something sharp. Avoid flimsy, open-toed shoes or flip-flops that offer little protection. Opt for sturdy, supportive, closed-toe shoes or well-fitting slippers with non-skid soles. Nail care. Be careful when trimming your fingernails and toenails. Keep them neatly trimmed and clean, but don't cut them too short or dig into the corners. And definitely never try to cut corns or calluses yourself. See a podiatrist if needed. It's too easy to cause a cut that bleeds significantly. Clothing. This might sound minor, but avoid wearing clothing that's excessively tight, or things like tight socks or elastic bands that could restrict circulation or cause skin irritation or chafing, which could potentially lead to a bruise or a small bleed under the skin.
Those are really tangible, everyday adjustments. Small things, but collectively they sound like they could make a huge difference in preventing those nuisance bleeds or even more serious injuries. It's really about being proactive and aware of your surroundings and activities. What about specific body care? Things like taking care of your mouth, or maybe issues like constipation.
Absolutely. These often overlooked areas need specific attention when you're on blood thinners. Mouth care. Good oral hygiene is still important, but you need to be gentle. Always use a soft, bristled toothbrush. Some people find an electric toothbrush with a pressure sensor helpful, or consider a water pick for cleaning between teeth. Use waxed dental floss gently. Avoid snapping it against your gums. Avoid harsh, abrasive toothpastes or using sharp toothpicks, which can easily irritate or cut your gums and cause bleeding.
Should you check your mouth?
Yes, it's a good idea to check your mouth daily. Look at your gums, tongue, inside of your cheeks for any signs of bleeding, unusual red or purple spots or sores. If you wear dentures, make sure they fit properly, as ill-fitting dentures can rub and cause sores. Remove them for at least 8 hours each day, usually overnight, to give your mouth tissues a rest. And crucially, always tell your dentist you're on a blood thinner before any dental work, even just a routine cleaning. They may need to take special precautions. Constipation. This is important because straining hard during bowel movements can potentially cause rectal bleeding or hemorrhoids that bleed more easily. To prevent constipation, focus on drinking plenty of fluids, aim for 8 to 10 cups of non-caffeinated liquid daily. Maintain a healthy diet rich in fiber from fruits, vegetables, and whole grains.
What if diet isn't enough?
Ask your doctor about safe over-the-counter options if needed. Gentle stool softeners like DOACs sodium or fiber supplements like psyllium or methylcellulose are often okay, but check first. Avoid harsh stimulant laxatives, enemas, or suppositories unless specifically advised by your doctor. And don't forget that regular physical activity also plays a big role in promoting healthy bowel function. Nosebleeds. These can be more frequent or last longer on blood thinners, especially in dry air. Use a humidifier in your home, particularly during winter when the heat is on. You can also apply a saline nasal spray or a thin layer of petroleum jelly, Vaseline or Aquaphor, just inside your nostrils daily to keep the nasal membranes moist and less prone to cracking and bleeding. Try not to blow your nose too forcefully.
And if a nosebleed does happen?
If a nosebleed occurs, sit down and lean slightly forward. Don't lie down or tilt your head back, as that makes you swallow the blood. Pinch both nostrils firmly together just below the bony part of your nose. Hold continuous pressure for at least 10 to 15 minutes without letting go to check. Applying an ice pack to the bridge of your nose and the back of your neck might also help constrict blood vessels. If the bleeding doesn't stop after 30 minutes of continuous pressure, or if it seems unusually heavy, you need to seek medical care.
That's incredibly thorough advice covering so many practical aspects of daily life. But, even with all these precautions, sometimes things still happen. When is it time to stop trying to manage it at home and actually call the cavalry, so to speak, get immediate medical help? What are the absolute red flags we should never, ever ignore?
This is perhaps the most critical piece of safety information. Knowing when to seek immediate medical attention is crucial. If you experience any bleeding, external or internal, that doesn't stop after 30 minutes of direct pressure, if applicable, or bleeding that is very heavy and seems uncontrollable, you need help right away. Call 911 or get to an emergency room. Any serious fall or significant injury to your head, even if you feel okay initially and there's no visible cut or bleeding, warrants an immediate medical evaluation. Internal bleeding in the brain is a major concern with head trauma when you're on blood thinners, and it might not cause symptoms right away. Be highly alert for any neurological symptoms that come on suddenly. This includes a sudden, severe headache, often described as the worst headache of your life, new confusion or disorientation, sudden weakness or numbness, especially if it's on one side of your body, or sudden changes in your vision or speech. These could signal bleeding in the brain.
Okay, uncontrolled bleeding, head injury, neurological changes, got it. What about signs of internal bleeding elsewhere?
Right, because internal bleeding isn't always obvious from the outside. You need to watch carefully for these signs. Coughing up blood or coughing up phlegm that is noticeably streaked or mixed with blood. Vomiting blood, or vomit that looks dark like coffee grounds. This indicates older blood from the stomach. For women, menstrual bleeding that is significantly heavier or lasts much longer than what's normal for your cycle. Urine that appears red, pink, or dark brown like cola or tea. Bowel movements that look bright red or are black and tarry in consistency. Black, tarry stools usually indicate bleeding higher up in the digestive tract. Frequent nosebleeds that are hard to stop or unusually heavy or prolonged bleeding from your gums when you brush or floss. Unusual bruising that appears suddenly without a known injury, or bruises that seem very large or are rapidly expanding or becoming very firm or painful. Sudden swelling or significant pain or discomfort in a joint or muscle, especially without a clear injury, which could indicate bleeding into that space. A severe unexplained stomach ache or abdominal pain.
That's a comprehensive list of warning signs.
It is, and any of these signs indicate that something potentially serious might be happening internally. You shouldn't wait or hope it goes away. You need to get to a hospital or see your doctor right away for evaluation. Don't delay. These situations are true medical emergencies where prompt diagnosis and treatment can make all the difference. #TagTagSees. Special considerations for the trail ahead.
As we start to round the bend on our deep dive today, let's just touch on a couple more special situations that require really careful thought when someone is taking these medications, particularly thinking about women's health here.
Yes, this is a very important and often complex area, especially when it comes to pregnancy and breastfeeding. For women who are pregnant, planning pregnancy, or are breastfeeding, the use of nearly all blood thinners requires extremely careful, individualized consideration. It usually involves a multidisciplinary healthcare team, maybe an obstetrician, a cardiologist, or hematologist, and others balancing the mother's health needs against the safety of the unborn baby or the nursing infant.
So it's definitely not straightforward. Are any of these medications considered safer than others in pregnancy?
Generally, yes. For instance, low-dose aspirin can be used safely by pregnant and breastfeeding women. In fact, it's often specifically recommended in certain situations, like for women at high risk of developing preeclampsia. Also, heparin, particularly the low molecular weight heparin forms like enoxaparin and Lovenox, is generally considered the anticoagulant of choice during pregnancy. The main reason is that heparin molecules are large and don't cross the placenta to reach the unborn baby. It's given by injection, which isn't always convenient, but its safety profile for the baby is well established. Heparin is also considered safe for breastfeeding mothers.
Okay, so low-dose aspirin and heparin are generally the go-to options if needed during pregnancy. What about the others? Warfarin, the DOACs.
Here's where it gets much more restrictive. Warfarin is generally contraindicated, meaning it should not be used during pregnancy, especially during the first trimester. It's well known to cross the placenta and can cause specific birth defects, sometimes called fetal warfarin syndrome, and it can also increase the risk of bleeding in the fetus throughout the pregnancy. The newer DOACs, like Eliquis, Xarelto, Pradaxa, and Fondaparinux, are also generally not recommended in pregnancy. There's simply limited data on their effects during human pregnancy, and because they are smaller molecules that might cross the placenta, there's concern about potential harm to the developing baby. The lack of extensive safety data means caution is strongly advised, and they're usually avoided.
So pregnancy really limits the choices, often pushing towards heparin if anticoagulation is essential. What about breastfeeding?
Breastfeeding is a bit different, but still requires careful consideration. While warfarin is often considered compatible with breastfeeding, the reasoning is that very little active drug seems to pass into breast milk, and it's unlikely to affect the infant. The situation with DOACs and Fondaparinux is less clear. There's limited information on how much of these newer drugs pass into breast milk and what effect, if any, they might have on a nursing infant. Because of this uncertainty, they should generally be used with caution during breastfeeding, and only after a thorough discussion between the mother and her doctor about the risks and benefits. Sometimes, switching back to heparin might be considered the safest option if anticoagulation is needed while breastfeeding. What's really fascinating and challenging in these situations is how carefully doctors must weigh the often complex, sometimes conflicting risks and benefits for both the mother and the baby. It sometimes means choosing an older drug like heparin, which might be less convenient, being injectable, simply because its safety profile during pregnancy or breastfeeding is much better understood than the newer oral options. The absolute key takeaway here is, if you require blood thinning and you are pregnant, planning to become pregnant, or breastfeeding, you must have a comprehensive discussion with your healthcare provider, ideally well in advance, to make the safest plan for both you and your child.
That really drives home the point again, doesn't it? Every individual situation is unique, and what's safe or appropriate for one person isn't necessarily right for another. It truly emphasizes that personalized medical guidance is absolutely irreplaceable, especially when dealing with these critical medications. #outro.
Well, we've certainly covered a lot of essential ground today, haven't we? We started by demystifying what blood thinners really are, remembering there about preventing clots, not actually thinning the blood's consistency. We dove into when aspirin is genuinely beneficial, especially noting the changing advice for primary prevention. We explored the different types of anticoagulants, from the veteran warfarin requiring careful INR monitoring to the newer generation DOACs that offer more convenience but still demand respect. We navigated that complex territory of interactions with vitamin K-rich foods for warfarin users, with common herbs, drinks, and a surprising number of other medications. And we spent significant time on crucial safety tips to minimize bleeding risks and recognize warning signs. If you're taking these medications or supporting someone who is, the biggest takeaways, the most important things to remember are these. Always talk to your doctor or pharmacist before starting, stopping, or changing the dose of any medication, especially blood thinners. Be consistent with your diet, particularly your vitamin K intake if you're on warfarin. And finally, be incredibly vigilant about preventing injuries and really knowing, those specific signs and symptoms that mean you need immediate medical attention. Your healthcare team is truly your most trusted guide on this journey.
That's right. You know, your heart's been tirelessly working for you since day one. It's a constant, vital engine doing its job without complaint, mostly.
Maybe it's time we all do a little something extra for it by staying informed, asking questions, and taking excellent care of ourselves. Remember, being well-informed is your best defense, your best tool in navigating your health journey. A little knowledge, a little caution, and a whole lot of care for yourself can go a very, very long way in keeping that ticker in top shape. We sincerely hope this deep dive has given you some valuable insights and empowered you to have even better, more informed conversations with your own healthcare team. Keep those questions coming. And be sure to tune in next time for another episode of Reading Cowboys Deep Dives, where we'll continue our heart health series. Because let's face it, there's always more to learn and more ways we can work to keep our hearts healthy. Adios for now, and keep your heart healthy.